السلام عليكم. I'm Dr. Rahma, Neonatology Fellow from Maternity and Children Hospital الأحساء. I would thank all organizers, especially Dr. Adnan, for such informative lectures. Today with Dr. Mansour Al-Quraishi. Dr. Mansour, he's the Division of Head of Neonatal Intensive Care Section at King Abdulaziz Medical City, Jeddah, Ministry of National Guard Health Affairs, and Associate Prof of Pediatrics at College of Medicine, Jeddah, King Saud bin Abdulaziz University for Health Science. Thank you, Dr. Abdulaziz, for the first part of lecture. Today we have the second part about the volume-targeted high-frequency oscillatory ventilation and neonates and new era. Dr. Mansour, the mic for you. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Give me just 15 seconds, please. Assalamu alaikum wa rahmatullahi wa barakatuh. Can I start now?
Yes,
تفضل دكتور منصور تفضل.
طيب بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. السلام عليكم ورحمة الله جميعا ومساكم الله بالخير. I would like to thank the Saudi Neonatology Society for giving me the opportunity again to present this presentation to our respected fellows and audience, and I wish it will be very beneficial to all of you. My topic title is Volume Targeted High Frequency Oscillatory Ventilation, a New Era. I'm trying to move the slide down, just a minute. Okay. I have to disclose that I have no potential or actual conflict of interest in this presentation. I'm finding difficulty in moving my slide. I apologize for that. So the outline of my presentation, I will go some introduction slide. I will show you with the goals of respiratory support in newborn infants. I will I will share with you the concept of ventilation-induced lung injury and what are the benefits of controlling tidal volume during respiratory support of newborn infants. Some of these slides are repeated from the previous presentation, but I think it's very important to, for the ones who did not attend the former presentation, to really share with them the concept, so it will be easier for them to grasp the new concept of using volume in high frequency. As we know, and you all know the concept of conventional high frequency without volume, I will try to shed some light on the effectiveness of use of high frequency for acute pulmonary dysfunction in preterm infants. and the concept of using volume and its potential benefits to reduce lung injury. I will probably share with you my own suggested practical guidelines for the use of volume guarantee with high frequency. Since 2015, we are using volume target high frequency in our center, and we built our experience with the use of that modality. And I think I could share with you our
قطع الصوت.
اسف، المعذره، اعتقد ان في تكنيكال
أيوة.
ايشو عندي، بس المعذره. طيب. Now, this is a introduction slide. I had it in the previous presentation. As you know, the goal of care in the care of preterm infant in the 80s and 90s.
Sorry, teacher, but the slide is
The sound is
not
not
showing. The sound is okay, but the
Is
slide
slide-
is not showing. Yes, sorry.
Okay, just give me.
You have to share it again.
I will reshare again. Sorry for that.
I think if we stop the video, Dr. Mansour, it will be more easy. I think الفيديو حتى كان هو يعني it's
Okay.
not يعني that good quality.
طب لو تعطيني، احاول اني انا بس يعني I think I need. اعطيني بس نص دقيقة او دقيقة السؤال الثاني. You see the slide now. السلام عليكم ورحمة الله.
أيوة
وعليكم
دكتور،
السلام
السلام
شلونك؟
عليكم.
عليكم السلام، شلونك دكتور؟
طيب، المعذرة بس شكله صار. So the goal of in the care of preterm infant in the 80s and 90s was to improve survival, especially for the severely immature preterm infant with surfactant deficiency. However, in the last 3 decades, the trend improving survival had leveled. In North America, in Europe, and Australia, you found survival rate for infant between 400 to 1500 did not differ for the last maybe a couple of decades. However, it's still there is opportunity to improve survival in developing country with resource deficient capacity. And for the past 2 decades, the emphasis has shifted from improving viability of preterm infant to improve functional outcome. So it doesn't matter that how many babies who are 24, 25, 26 go home, but how many of them they go home with intact survival, with normal brain, normal eye, and normal lung, and hopefully normal neurodevelopmental outcome. Unfortunately, the incidence of chronic lung disease from North American data subsequent to ventilation has not improved significantly since the introduction of surfactant back in the early 1990s. And there is a shift from why and how to ventilate neonates, and particularly preterm infant, so how best to support them without major sequelae of ventilator device. And what ignited the way to ventilate and how best to do it is the Columbia approach, where this Columbia approach championed by Dr. Wong of using not to intubate neonate and premature infants and to use CPAP. And that ignited interest in non-invasive respiratory support. I show this slide in all my presentation when I give a respiratory presentation to remind myself and remind the audience that when we ventilate a newborn and particularly a premature infant, we are dealing with a developing lung, developing alveoli, which in the various stages. So any wrongdoing will lead to either a transient or permanent damage. And we can damage the lung either by using high pressure, we call it barotrauma, by using high volume, we call it volutrauma. When we collapse the lung, we lead to some and that lead to biotrauma. And in addition to that, we use oxygen frequently, and we sometimes we keep the oxygen sats above the target, and that lead to oxytrauma.
Sorry دكتور منصور, we need to reshare the slides again because يبدو النت فصل عندك ورجع مرة ثانية.
والله أنا آسف اليوم شكل السلايد okay, it's more complicated. Do you have it now? Do you see it now?
No, not yet, Doctor.
لسه.
Sorry.
Not yet.
So I'll stop sharing and then reshare.
Now, yes, Doctor. It's showing.
Do you see it? والله المعذرة. Okay.
Yes, الآن موجودة.
طيب, this is another graph I always show to indicate that when we ventilate newborn and premature infants, we have to ventilate them in the middle way. This is a pressure volume curve. When we open the lung too much, we cause volutrauma. So when the lung reach its maximum sensibility, that will lead to high lung volume NG zone. The same time, when we lower the pressure, lower the tidal volume, that أسأله.
أيوة دكتور. برضو شكله قطع ورجع مرة ثانية.
دقيقتين, شكلي عندي مشكلة في الكمبيوتر, أنا آسف والله المعذرة, بس give me 2 minutes. Sorry for this interruption. Just give me 2 minutes. هحاول إني أنا I will just troubleshoot. السلام عليكم ورحمة الله. السلايد واضحة الآن؟ هاي دكتورة عدنان. دكتورة
أيوة، في الباك جراوند حق الجهاز، بس لسه مش السلايد، بس في صورة الآن.
الباك جراوند حق الجهاز، أيوة، بس ما في
أيوة
الصورة حقت البرزنتيشن.
أيوة. عذرا دكتور منصور، بس الصورة اختفت مرة ثانية.
ما سمعتك دكتورة.
راحت الصورة، ما عاد في شيرنج الآن.
موجودة الآن الصورة؟
أيوة الآن طلعت.
والله I hope
الآن
I
أوكي.
could manage this. طيب. Now you see the slide, you see that you hear me well. I hope it will not be again happening. Sorry for that. So
أيوة الآن أوكي.
the concept of using high frequency oscillative ventilation is not something new. It's been for the last probably 3.5 decades. And the definition of supra physiologic rate, meaning we use frequency, we don't call it rate, but typically the rate should be above 180. Each 1 hertz is 60 breath. So if the rate is more than 180 per minute or more than 3 hertz, we call it high frequency oscillatory ventilation. And we use constant descending pressure. We call it MAP, and the MAP should be above the functional residual capacity. And we use oscillatory pressure. We call it amplitude or delta P, which is the volume of the breath up above and lower than the MAP. And that the aim is to produce small tidal volume, smaller than the dead space. This is the famous SensorMedic 3100, which has been used for the last 3.5 decades since introduction. And I think the look of it is the same since it was produced in the late 80s. What are the potential benefits of using high frequency? Because in the high frequency, the concept, we use a small tidal volume, usually lower or equal to anatomical dead space volume, and that potentially may reduce the risk of polytrauma. In addition, that we use lower peak distal alveolar pressure to facilitate gas exchange, and that potentially reduce the risk of barotrauma and eventually polytrauma. And we use continuous descending pressure, we call it MAP, and that to enhance maintenance of optimum lung volume. This is the high frequency. This is a slide show you the time and pressure. So in this slide, it's 3 hertz, meaning there is every 1 second there is 3 breaths, and this is the MAP. So we open the lung to the MAP, let's say 15, 16. And then we oscillate frequency, and this slide 3 breaths per second. which is called 3 hertz. And then we oscillate the pressure around the map, and we call it the amplitude. So again, to illustrate to you, this is a slide, time and pressure. So we have the map, let's say 15 here, wavelength to 15. We oscillate around the map, and that called amplitude. So the depth inward or outward is called amplitude or delta P, and the frequency is 3. We know that when we use high frequency oscillatory filtration, there is, in contrast to conventional ventilation, we have dampening of the pressure. So the pressure at the opening, airway opening, see the pressure is high. Once it reaches trachea, it dampen, and then the alveoli, it will be significantly dampened. And this is a concept of high frequency. So the pressure at the airway opening is much, much lower than alveolar level. This slide shows you the difference between pressure damp during high frequency oscillation and conventional ventilation. In a normal compliant lung, the green graph indicates the high frequency pressure, and the black one is the conventional. As you can see, in a normal compliant lung, the pressure doesn't dampen with the conventional, so it remains. So whatever at the airway pressure opening is similar to the large airway and similar to alveoli in a normal compliant lung. However, in high frequency, you see the pressure dampen at the large alveolar airway, and it's actually dampened significantly at the alveolar level. This is in a normal compliant lung, and also in low compliant lung. However, the dampening, when you have a low compliant lung, means sick lung, the dampening is not as very low as compared to the compliant lung. But the concept of this slide to show you that the airway, the pressure dampen during high frequency and does not dampen or does not reduce using conventional ventilation. All the fellows knows, and my colleagues knows, that when you have a problem with oxygenation in high frequency, there is 2 ways to improve oxygenation. Either to increase, if the baby had, let's say, oxygenation problem, the first reaction is to increase the FiO2, and also we can increase the manual pressure or continuous distinct pressure. When we have a problem with CO2, as you know, we have to improve, regulated by the amplitude as well as the frequency. So when we have a problem with CO2, let's say a CO2 of 70 and the pH was 7.2, and we wanted to reduce the CO2 and improve the pH, we have 2 ways, either to increase the amplitude delta P, and that means we increase the volume of the breath, and that will lead to more CO2, higher tidal volume, and subsequently more CO2 elimination. When it comes to frequency, in contrast to the conventional ventilation, when we increase frequency, we actually significantly lower tidal volume, so it will increase CO2. So if you have a baby, let's say in a high frequency and frequency of 8, and you want to, and the CO2 was high, and you are allowed to choose the frequency to bring up or down, you will be reducing the frequency, because when you increase frequency, you are actually increasing tidal volume and you increase CO2 removal. So tidal volume falls as frequency increase due to shortening of absolute tidal volume, less time for tidal volume delivery. But so mentioning that, we have significant challenges in the initial use of high frequency in neonates. And the initial slide, I show you the sensor medic. And that machine, tidal volume is not measured nor controlled. And we tend to actually drive CO2 low. And most of our senior colleague knows, when we start using high frequency in the 90s and the last 2 decades also, we found that most of the time when we start high frequency, you find the first CO2 will be lower than what we want. So the rate of hyperventilation and driving CO2 is much higher than conventional ventilation. A third challenge, as I mentioned earlier, that higher frequency affect the tidal volume adversely. So when you increase frequency, you reduce tidal volume significantly, and that's why it is a bit challenge. You cannot use high frequency because every time you use higher frequency, you reduce significantly the tidal volume. And this is a very good slide to explain to you what I mentioned earlier. As you can see, this is the frequency from 5 to 15, and this is that volume. As you can see very clearly, with increasing frequency, you adversely lower the tidal volume. So with each increase from 5 to 6, you double the reduction in tidal volume because it's V2 squared. So this is why when we increase frequency, we also lower the tidal volume significantly. So this slide shows you that increasing frequency always in conventional high frequency will reduce tidal volume and reduce CO2 elimination. I hope I convinced you in the last presentation ago that using volume target in preterm infants versus pressure limited is beneficial. And the summary of the finding of Cochrane I mentioned a month ago, that using volume targeted conventional ventilation is superior to pressure limited because we have lower BBD, less death, or BBD, less IVH, and less BV, and less hypocarmia compared to the pressure limited alone. However, using high frequency in general and using high frequency with volume, I will show you the data. Now we'll start with elective high frequency versus conventional for acute pulmonary dysfunction. This is a Cochrane review published on 8 years ago. There is a 19 randomized control trial were included, and there was more than 4,000 preterm infant included in this review. Do you hear me, دكتور عدنان؟
واضح الصوت دكتور منصور. أنا وقفت الفيديو عندك، أعتقد الصوت بعد تحسن.
ممتاز عشان بس اتاكد لانه الانتربشن initially made me worried about okay. طيب, so this is a Cochrane review, as I mentioned, included 19 trial, more than 4,000 per infant included, just to see whether elective high frequency versus conventional is beneficial or no. They try to evaluate the mortality, the chronic lungs, and other prematurity completion in the two, either elective high frequency versus conventional ventilation. And the data, as I mentioned, as I explained to you now here, there was no difference in death at 28 to 29 days. There was no difference at the correct gestation age of 36, 37. So the relative risk was, and the CI included. There was slight reduction in chronic lung disease. I see 30% in the high frequency, 35. Relative risk is 0.86, and it did not cross 1. So statistically significant, but was not clinically significant. So when you have the composite outcome of death or chronic lung, there was more of improvement, composite outcome in favor of high frequency electively. However, I have to warn you, these they are driven from center where they use high frequency days in out in certain part of Europe. So sometimes it's their primary ventilation strategy. So they are very and they have experience about it. But I'm sure maybe other centers have different view. Now Air Leak was probably the same, 10% in the frequency, 9.4 conventional. The risk was 1.1 and lost 1. There was slight increase in the grade 3 and 4 IVH in the high frequency electively versus conventional, but as again did not reach the statistical significance. Also ROP who were conventionally ventilated. So the conclusion of this Cochrane review that high frequency oscillatory ventilation versus conventional in preterm infant, there is no difference in survival at 28, 29, 28, 30 days. There is no difference when they reached correct gestation age of 36, 37 weeks. There is no difference in severe IVH grade 3 and 4. However, there was slight increase in the high frequency group, no difference in air leak, some reduction in chronic lung, and some reduction in stage 2 and above ROP. So the conclusion or the summary of the finding according to the reviewer, no effect on mortality, less chronic lung in high frequency, but it was not was inconsistent and trend toward higher severe IVH BVL in high frequency group. So this is why I think high frequency as an elective device for acute pulmonary dysfunction prevent is not very much used. Most of our center, they use high frequency oscillatory ventilation as a rescue when the premature infant or newborn infant fail conventional ventilation and they go to high frequency oscillatory ventilation. And I think the reason because it did not show superiority because of the challenges I mentioned earlier. So now the new era is we can measure tidal volume during high frequency. Not only we can measure tidal volume, we can control the tidal volume and we can adjust the amplitude accordingly. Now we could use higher frequency. You remember when I mentioned earlier that in high frequency, always when you increase frequency, you lower tidal volume. Now when you fix or guarantee the tidal volume, so you can use higher frequency with a lower tidal volume to maintain adequate minute ventilation. This slide is just to give you the comparison between conventional ventilation using volume guarantee and high frequency oscillation using volume guarantee. Here, this is a pressure curve. As you know, we set the PIP, the maximum PIP in conventional with high frequency, usually 3 to 5 centimeters above the measured pressure. So let's say the baby in conventional with volume guarantee, and he require 18 pressure, we set the maximum PIP to be 22, 23. So, and when the baby get better, you find the pressure requirement in conventional goes down automatically. The same concept in high frequency. What we do, we set the tidal volume and then we see the gas and we say this is an acceptable gas for that specific disease, that specific baby. And then we actually, the amplitude will be regulated and controlled similar to the max PIP in conventional. So here I say, let's say the baby delta P required, let's say he's in a map of 16, amplitude he required to achieve the tidal volume 35. Then we set it usually 5 above the maximum delta P, and you find the amplitude, it's not fixed, so it's regulated according to the tidal volume. And in this concept, you find the baby in the beginning, when you ventilate him, he would require, let's say, amplitude is say 40. And then when the baby improve, his compliance improve, his lungs improve, with the same tidal volume, you find the pressure goes, the amplitudes or delta P goes down by itself. So this is a concept. In conventional volume guarantee, the PI, maximum PIP, the PIP measured get lower according to the improved in lungs. In high frequency with volume guarantee, you find the amplitude goes down by itself to maintain the tidal volume you are setting or guaranteed. CO2 elimination during high frequency. As I mentioned earlier, that when we try to remove or high CO2, there is very important concept equivalent to minute ventilation in conventional ventilation, or minute ventilation in conventional, which called DCO2. DCO2, it means diffusion coefficient of CO2. It's a value which reflects the power of CO2 elimination. So if you have high DCO2, that means you are having high power to remove CO2, so higher minute ventilation. And it's a minute ventilation analogy when using high frequency. This is the equation. DCO2 equal tidal volume squared by frequency. So as you can see that when we want to increase dCO2, meaning CO2 removal or the power to remove CO2, either we increase tidal volume or increase frequency. Now I bring you back to the slide. You remember that when we use high frequency without volume, every time we increase the frequency, we lower the tidal volume. And that happened because we lower, the tidal volume goes down by square. So if you go from 5 to 6, 6 to 7, 7 to 8, the tidal volume go down and down significantly. So the concept of high frequency with volume is that we fix the volume. When you fix the volume, you can increase the frequency to much higher level without affecting volume. So that makes the concept of high frequency oscillation more feasible. So you use a fixed tidal volume, lowest tidal volume, and you use the frequency to wash CO2 with minimal, very minimal tidal volume. And that hopefully will reduce volume trauma. That's the concept. That by data now prenatalology. It's an animal experimental data. They studied piglets' lung. They induced respiratory distress syndrome, and there were 20 piglets. They are aged 1 to 2 days, and they have two strategies. One strategy use high tidal volume with frequency of 10 versus a low tidal volume with frequency of 20. So in one arm, they use high tidal volume with a lower frequency, and the other arm, they use a lower tidal volume with high frequency with comparable CO2, PCO2 level. And then they looked at the histology of those lungs. They found piglets who were ventilated using high volume with lower frequency had more severe histological lesion and infiltrate in hemorrhage in the alveoli compared to the ones used lower tidal volume with higher frequency. So there is a potential less lung injury when you use lower tidal volume with higher frequency in this studied animal models. This is a slide. I will go through it, but I'll share with you the presentation later. But definitely this data, this is another data by the same researcher published almost 7 years ago. It's actually clinical data. It's a pilot data. They have 22 newborn infants with RDS on high frequency with volume guarantee. So what they did in this trial, they reduced tidal volume and they increased frequency to maintain a constant CO2 elimination. And they did pre and post PCO2 assessment, amplitude assessment, and tidal volume, and compare them. In this data, they found that increasing frequency while reducing tidal volume maintained similar CO2. So when you increase frequency and you fix the tidal volume, you actually achieve a decent CO2 elimination.
قطع شوية الصوت قطع ورجع.
ايوه طيب.
الآن رجع.
طيب, so tidal volume was significantly lower. It was 2.2 before versus 1.5 after reaching the highest frequency. And this strategy in this published paper indicate potentially that use lower tidal volume with higher frequency may reduce lung injury. So this is the table 2 of that study. As you can see here, they started with frequency of 10, they increased it to 16. At the same time, they reduced tidal volume from 2.2 per kg to 1.5, and they found comparable, the FI2, comparable SATs, and much reduction in CO2. So this is another study published almost 8 years ago by SCAN. They had 22 infants less than 32 weeks required invasive mechanical ventilation. They randomized them either to high frequency with volume versus conventional high frequency without volume, and crossed over to the other mode after initial stabilization. So the conclusion of this study that high frequency with volume is feasible and provide more constant ventilation and gas exchange. However, because the small study and further randomized control trial with a larger sample size was needed. This is very interesting slide. I want you to spend time and share. This is the slide comparing high frequency with volume and high frequency without volume. 80% of the time, if you use volume guarantee with high frequency, you will be at the target tidal volume. And only 20% either you are lower than target tidal volume or higher than tidal volume. But if you don't use volume guarantee, you are only 35%, 1/3 of the time, you will be at the target tidal volume, but most of the time will be under the target and off the target. So this slide indicates to you that when you use volume guarantee, you most likely will be within the target tidal volume much more and significantly much more with using volume guarantee. This is another slide from the same research or paper. They looked at the PCO2. And they consider PCO2 between 37.5 to 52 is the target, and below 37 is low PCO2, and more than 52 above. They found the chance that with volume guarantee, the chance to be within the target much higher than if you don't use volume, if you don't volume guarantee. So that means the level of PCO2 will be much more consistent and constant and within the desired PCO2 level if you use volume guarantee. So the result of this study that PCO2 and mean tidal volume was significantly higher in the high frequency using volume, and hypocapnia and hypercapnia were lower if you use volume guarantee with high frequency, and it potentially may reduce lung injury. This is another interesting study. It's published almost a year ago, or less than 1 year ago. It is a randomized controlled trial they conducted in tertiary care teaching hospital in China. They have 29 and underwent cardiac surgery versus 29 newborn infant underwent cardiac surgery, and they randomized them either to be in high frequency alone without volume and high frequency oscillation with volume. And they looked at their inflammatory marker, interleukin-1, interleukin-6, 8, tumor necrosis factor 1 alpha, and analyzed them from the tracheal aspirate in day 1 and 2 and 3. And in this study, they found there is increasing trend of interleukin-6, 8, tumor necrosis factor 1 alpha on day 2 and 3 in the high frequency group compared to the volume guarantee group. That means there is much less inflammatory marker on their lungs if you have used volume guarantee. And there was significant increase in day 3 in the high frequency ventilation without volume. In addition, in this study, they found that hypocapnia and hypercapnia events were significantly higher if you use high frequency oscillatory ventilation alone without volume guarantee. So the conclusion of the study that high frequency oscillatory ventilation with volume compared to the conventional high frequency without volume post-cardiac surgery reduce post-inflammatory systemic reaction, and you have less CO2 higher and lower than expected or desired CO2 level. So I can tell you that the data is not yet robust. It's not similar to the data I presented a month ago with regard to use volume with conventional, but I think we are building our experience. I think there is more studies are coming in the way. Hopefully, it will probably either prove superiority of using volume targeted high frequency over high frequency alone. But I think I don't think yet we have a robust evidence to suggest that it is the way to go. However, based on our experience in our hospital, where we use high frequency oscillatory ventilation with volume for the last probably 7-8 years, we use it as a rescue and respiratory support for newborn infant with respiratory insufficiency who fail non-invasive. So our aim is to not to ventilate, but using non-invasive. Then we go to volume target conventional, and then if it fails, we go to volume target high frequency. So non-invasive, volume target with conventional, it failed, then we go to as a rescue to volume targeted high frequency. We set the map similar to the conventional high frequency, usually around 2 to 3 centimeters above the closing pressure after lung recruitment. So if the baby requires, let's say 14 on conventional, we set it around 16, 17. And then, we look at the X-ray, we look at the FI2, etc., in order to have the desired map. So the map setting is not different from the usual high frequency without volume. The tidal volume, I suggest to start with 1.5 mil per kg. So if you have a baby who's 1 kilo, you start with 1 mil, 1.5 mil. And then you titrate your tidal volume according to blood gas, according to the CO2 value you have there, and the trend of such values. I recommend to start frequency of 10, and then you can go higher, because as I mentioned, because now the disadvantage of the old conventional high frequency, that when we increase frequency, we always lower tidal volume. Now, when we fix the tidal volume, we can play with the frequency to achieve better ventilation. So use higher frequency and lower tidal volume. Use I time of 1 to 2 when using high frequency with volume guarantee. So in conclusion, volume target high frequency is promising respiratory support modality for treating newborn infant with respiratory failure when non-invasive and volume target ventilation fail. High frequency ventilation with volume allowed to use lower tidal volume than dead space by using higher frequency to maintain acceptable CO2 elimination. However, further larger studies are needed to evaluate its comparability or superiority to over the usual high frequency without volume guarantee, and its applicability for various respiratory conditions with heterogeneous etiologies and underlying pathophysiology. Thank you. I apologize for the significant interruption of the connection at the beginning, but sorry for that.
Thank you, Dr. يعطيك العافية. Any question? We have a question here. What is the limitation of high frequency with volume guarantee?
What is the
limitation
دكتورة
of
تعيد
high frequency? What is the limitation of high frequency with volume guarantee?
Limitation first is, I think we have to build our experience. As any other modality, I mentioned it maybe before for the first presentation, always when you use something new, we have to build our experience. We have to have a significant, robust teaching and education and hands-on training for our nurses, our physicians, our respiratory therapists. This is very important, because if you want to fail, don't train people, educate people, do service enhancement and service training for them. Because I found sometimes when you use something we are not trained to do, we fail, and then we think the failure is due to the device or the concept of that specific modality. So I think the challenge of using it is the experience with it. Secondly, and I think what happened, I found it sometimes challenging. Sometimes we set the tidal volume, let's say 1.5, and then we set the maximum delta P, let's say 40. And then you find the baby only take 30 delta P, and he doesn't reach the tidal volume. So that means this was a challenge. I found it difficult for me. What I suggest in that scenario is to make sure that your IE ratio is 1:2, and that's one thing. Second, make sure there is no leak, because always when you use volume guarantee, if there is a leak, it will be not accurate, because if because the flow sensor of the device measure the expired tidal volume, expired things. So if you have significant leak, then what is measured at the expiratory limb is much lower than what delivered. So that will be, so make sure there's no leak, make sure people are very trained with it. In my experience and our experience in National Guard in Jeddah, I think 80% of the time we found it very helpful. 20%, 25%, we found that when we use it with challenge, then we go back to conventional, either high frequency or conventional pressure, conventional ventilation. But we build, if you ask me, 7 8 years ago, we used to be using it 15, 20 times the percent times, 20% at that time. But when we build our experience, we found that we use it much more frequent. Currently, 80-90% of the time when we use high frequency, we use with volume. I hope I answered some of the challenges you raised.
Also, we have another question, Doctor. What is the range of volume, the minimum and the maximum with high frequency? And do we change the tidal volume according to the blood gas?
Yeah. So what I suggest, because as I mentioned earlier, that when you started using volume guarantee, you start with 2 mil or 2.1 mil, but there is a robust data to suggest that we should use a much lower tidal volume and use higher frequency to achieve a normal gas exchange. So I suggest to start with 1.5 mil per kg. So 1 kilo baby, you give him 1.5, 2 kilo baby, 3 mil, and then look at the DCO2. DCO2 is, there is no magic number, like what is the good DCO2 for that baby is different from the other one. Look at the DCO2. So now let's say, I'll give example. We start with 1.5 mil per kg, let's say frequency of 12 or 10, and amplitude, let's say 30, for example. And then we found the baby first blood gas, let's say PCO2 50 or 48, pH 7.3. So we will keep there. However, we found that this PCO2 went higher, let's say 65 and the pH 7.24, and then we have to do something. So what I suggest to you, start increasing frequency. And then if you find you reach higher frequency, but still you have a problem with CO2, then you can increase tidal volume. You start with 1.5. I think you can go up to 2.2, but I don't think if you go higher than 2.2, I think you are using very high tidal volume. 2.2 in high frequency ventilation with volume is equivalent to probably 6.5 to 7 mil in conventional. So we usually do not go that high in conventional with volume guarantee ventilation. So 1.5, frequency of 10 to 12. Look at your PCO2, look at your pH, look at your DCO2, and monitor your DCO2 frequently. And sometimes the good thing about high frequency with volume, because DCO2, it will reflect your PCO2 level. For example, if you find your PCO2 level is say 45, and your DCO2 is, let's say for 1 kilo is around 70, then if the DCO2 goes high, that means you definitely know that CO2 is lower now. If your DCO2 goes down, so by looking at the machine, you can know that your PCO2 level is higher or lower. So you could do gas and to prove that. But definitely with the use of volume guarantee, high frequency, and using DCO2, you may actually reduce the need to do blood gas, because you have a numeric number on the machine can tell you, indicate to you the level of PCO2. Hey, Doctora.
أيوة دكتور. Also, we have another question. That is what are the possibility of developing pulmonary hypertension in neonates on high frequency and pediatrics. Sorry.
يعني there's no relation between يعني high frequency and I think يعني many times babies who have PPHN, diaphragmatic hernia, etc. You probably end by putting them or electively put them in high frequency, and I do suggest to put them in high frequency with volume. So I think I don't. The question indicate or tell me that there is risk of PPHN more with the volume, or it will treat
يعني
PPHN.
the question was developing of pulmonary hypertension on high frequency of the baby on high frequency. That's what I understand.
I don't think there's no risk. Actually, the baby have PPHN and they have respiratory cause of PPHN. We end we put them in even conventionally failed, go to high frequency, and you can use volume guarantee. So I think that there is no risk that the PPHN goes higher with. And I showed you this data from the Chinese data where they have post cardiac cases and they put them in high frequency with volume, and they found they do better than babies who are on high frequency without volume.
Okay, thank you, Doctor.
Another question about كان في سؤال في دكتورة يعني developing PPHN، كان في سؤال آخر أعتقد.
Sorry, Doctor.
كان في another question. في سؤال كان غير ال PPHN the same.
في كان اللي قبل كان في it is mandatory to put all the patients with air leak on high frequency as a gentle ventilation.
طبعا هو يعني if you remember I mentioned the high frequency conventional high volume compared to conventional ventilation. There was no increase of there was slight increase in air but not such significant. لكن there is no data to either to prove or to decline the concept that air leak is more with volume. In fact, conceptually, you will have lower air leak if you use volume because the volume trauma is probably the main reason why babies they have air leak. So I do suggest if you use properly volume targeted high frequency, you probably will have lower air leak syndrome.
Also,
تفضل.
sorry.
تفضلي
Also,
دكتور.
there was a question if we can use the high frequency with VG as initial mode or only if failed or conventional.
As I mentioned, nowadays, if you have a babies who require respiratory support, start with non-invasive CPAP or non-invasive ventilation. If fail, you go to conventional ventilation using volume. So assisted control with volume guarantee. If fail, I do suggest you use high frequency with volume. So I think it is. Now the data is no robust, but in our center we use it frequently, and you find it is superior to high frequency without volume. So if you have a baby who has respiratory insufficiency for any reason, use non-invasive CPAP or non-invasive ventilation. Then if fail, go to invasive ventilation using volume guarantee with assist control, for example. If fail, rescue, use volume guarantee with high frequency. This is what I do, but I'm sure if you use high frequency alone without the volume guarantee, you could do that. But I think the concept of using volume guarantee, because you will have more consistent tidal volume delivery, you have less chance to have less chance of hypercarbia, hypocarbia. You will have probably less potentially less lung injury than without volume.
Okay, thank you, Doctor. Also, Doctor, we have a question. If high frequency delivering a small tidal volume smaller than the dead space, so why the technology add volume guarantee to high frequency?
As I mentioned, the challenges we had before in using high frequency without volume guarantee. First, we don't know what tidal volume delivered. We will know by the first PCO2 of 20. I'll tell you, most of us in the past, when we use high frequency, we know that the first PCO2 most likely will be very low. The patient was, let's say, CO2 65, 70, and then you put him in high frequency and you found CO2 went down to 20, 25, and pH from 7.2 to 7.45. So very commonly, especially if my senior colleague are attending this presentation, they know what I'm talking about. Using high frequency without volume guarantee, the chance of having very low CO2 is high. So now in the old, the high frequency without volume, you cannot control the tidal volume. And the other problem, as I mentioned, that in the conventional high frequency, when you increase frequency, you lower tidal volume. So you have a problem. So you wanted to use a lower tidal volume, but because when you increase frequency, you lower tidal volume. So you end by having high CO2, and then that's why you tend to give delta P higher to achieve tidal volume. Now, with a volume guarantee, you fix the tidal volume and you can use frequency as a tool to improve CO2 elimination and make the DCO2 higher and lower PCO2, and that actually it is the way to go in when you put patient high frequency, to use the smallest tidal volume with highest frequency. I hope I answer the question.
Okay, thank you, Doctor. We have also another question here about there is upper limits for MAP or delta B.
Now MAP, when you start MAP, the MAP is similar to the MAP used in high frequency. Sorry, I call it conventional high frequency. Conventional means the without volume guarantee. So setting the MAP, usually we set the MAP 2 to 3 centimeters above. So, for example, if the baby was in conventional and he failed, and we have to rescue him with high frequency, we set the MAP 2 to 3 centimeters above the conventional. So if he was requiring 14, we set 16. Then we look at the FI2. The standard teaching, when we put the patient high frequency and we increase the MAP to let's say 2, we increase the MAP until we reach 60%. So FI2 goes down 60%. And then you do an X-ray, you see the lung volume. And usually you like to see around 9 reps, slightly flat diaphragm, but not very flat, not hyperinflated. So the MAP 2 to 3 centimeters, you increase to reduce the FI2 to 60%. That your MAP which you set, and then you do an X-ray. You look at your lung volume in the right and left. So usually you like it to have around 9 reps, but not very flat diaphragm, but slightly flattish, but not domy diaphragm. And then you look at the blood pressure, because definitely MAP affect your venous return and IVC return, so you may have a problem with blood pressure. So setting the MAP is exactly the same like setting the MAP on conventional high frequency. The other question is the MAP. The other one is what, Victoria?
The delta B, the maximum delta B and
tidal volume or
delta B and delta B and
delta P, the classic teaching, you are fellows, mashallah, we like to have a clinical oscillation. So we like the oscillation until, lower abdomen, but not the thigh. So you look at the oscillation yourself. So that's clinically. But usually what we do in volume guarantee, let's say if the baby required to achieve the tidal volume delta P of 32, he's a MAP of 16, I assume. And then you see that you set the tidal volume, let's say 1.5 for 1 kilo. And then you find that he required to achieve that 1.5, 35, you set it 5 centimeters above the measured delta P. So so this baby now, he's the same like maximum BIB on conventional with volume. Here it's maximum delta P. So meaning that the baby required 35, but you set it to 5 above the 35. And then you find the baby, by the way, when the baby gets better, you don't need to lower the delta P. It goes down by itself. And this is the beauty about volume guarantee, because once the lung complex improve, same like the concept in the conventional ventilation volume guarantee, you put the max PIB, let's say 22, and you find the baby require initially 18, but later without touching anything, you find the baby require 12. Here the same, delta P, without touching it, you set the max, so it doesn't go higher than that. So you find the baby when his lung compliance improve, his lung get better, you find with the same tidal volume, your delta B was 32, 35, and it goes to 25 by itself without you changing the delta B. So then you lower your max delta B. So for example, now if you require 25, you set it 30. If you require 35, you set it 40. So usually 5 above the required delta P to achieve the tidal volume. The third about what, the frequency or what?
لا هذا خاص this is about the maximum. We have also those two
ايوه
questions.
الدلتا بي ما تكون عاده more than 3 times الماب، يعني be careful about it. The maximum is 2.5 to 3 times the
yes. There's one question. What is your opinion about non-invasive high frequency?
Non-invasive high frequency.
Yes.
Well, to answer it, I don't have experience with it. However, يعني we know that bubble CPAP يعني هو يقولوا there is some oscillation. When you deliver CPAP, there is oscillation, by the way. So the simplest non-invasive high frequency is CPAP, by the way, especially the bubble CPAP, because when you have the bubbling, that bubbling will be seen by the baby lungs. So there is some element of high frequency there, by the way. However, I don't have experience with using non-invasive high frequency. But I can look it up to you and send it to the group if I have some answer to that question.
Okay, sir. Yes, sir. It will be the last question. Regarding of the weaning from high frequency, do you need wean to a conventional, or we can extubate baby directly from high frequency?
طبعا يعني we wean from high frequency, and of course when we reach MAB of, let's say, less than 14, less than 12, when we find the baby in lower FI2, we wean. In my experience, I usually do not go from high frequency to extubate. I tend to put them in conventional with volume guarantee. So if the baby is high frequency and reach MAB of 12, and if I2 went down to less than 40, and the baby tidal, delta P is minimal, then I shift him to conventional with volume guarantee, and then later we can put him in non-invasive. In my experience, I usually go that way. So in escalation, I go from non-invasive, conventional ventilation with volume guarantee, and high frequency with volume guarantee. When I de-escalate the therapy, high frequency with volume to conventional with volume, and then non-invasive, either CPAP or non-invasive. But usually I do not extubate from high frequency to non-invasive. This is my experience, but I'm sure maybe some other do, but this is my experience with the way I do things in my practice.
Okay, thank you. There's a lot of the question actually, but because of the time, we cannot answer them all. Thank you, Dr. Musa, for this informative lecture.
And again, I apologize.
That give us our time.
I apologize for the technical issue, and
we appreciate
inshallah in the
future your time. Thank you, Dr.
Okay, thank you very much. I thank my daughter Lama, who's helped me in the technical troubleshooting.
البروف النمري كان رافع يده بس you can talk.
انا رافع يدي والصفحه بس.
والله
تفضل.
اعتذر يا بروف على التكنيكال.
شكرا يا منصور. It was great. لا it was great. انا بس عندي 2 comments. بكده انت خلاص ما شاء الله الفنتليشن، يعني الفيلوز الان ما عندهم اي اكسكيوز انه they don't know the ventilation ولا we need another lecture. we need another lectures. Two comments. أنا ما سألت عن الفيجي والتكنولوجي. You're absolutely right. The only advantage that they get it, swinging of CO2 from higher hypercapnia is dangerous. Hypocapnia is as dangerous as hypercapnia. CO2 of 70, 50 is vasodilators, vasoconstrictor, this vasodilators, vasodilator, vasoconstrictor, IVH is going to be the end result. But VG make this stop this drop in the CO2. في عندي announcement. انا اعتقد ان احنا وصلنا الى how many lectures عدنا الى so far 20
لا وصلنا تقريبا ل 15 تقريبا
15 قلنا احنا كنا ناويين نسوي ل 20. we need to go back to our activities as neonatology club في كل البرانشز في المملكه سواء كان في الجنوب في الغربيه والمناطق المختلفه اللي فيها عندنا فروع مختلفه. Neonatology Club will be activated by September بإذن الله تعالى. هنبدأ بالرياض ويمكن في جيزان عندهم برضو نفس الشيء، في الشرقية، في الدمام، في تبوك، في الشمال، في جدة، في كل مكان. And I will just encourage all the fellows to participate in our Neonatology Club by their presentation, either as a review or if they have a basal case presentation, they are most welcome. والدعوة للجميع الموجودين من البارتيسيبانت الحاضرين هذه الليكشرز. شكرا دكتور منصور، شكرا دكتور عدنان، يعطيكم العافية، نستودعكم الله.
شكرا جزيلا بروف، يعطيكم العافية، جزاكم خير. طبعا هي بعد بدء الفيزيكال ليكتشرز او النيوناتولوجي كلابس راح يكون في تخفيض لعدد المحاضرات، اكيد ما راح تبقى اسبوعيا ان شاء الله تعالى، يعني it might be monthly غالبا يعني soon. شكرا جزيلا.
شرفتوني دكتور عدنان.
شكرا جزيلا. شكرا
مع الزملاء والزميلات، وانا استفدت كثير من الاسئله المطروحه عشان الواحد يراجع بعض الداتا. والابديت يو ذا انسر ذا كويشنز انسر اللي ما كان عليها مثلا اجابات.
شكرا جزيلا. شكرا
لكم.
شكرا.